Hello everyone and welcome. I'm Dr. Domkowski, and tonight we'll be giving a Facebook Live presentation from Steward Sebastian Bariatric Surgery Program and Sebastian River Medical Center. This is our monthly free online seminar, so thank you for joining us. We're glad you could be here. Tonight's topic is on reducing medications through weight loss surgery. As you all know, as your BMI or body mass index goes up, your risk of developing other diseases in relationship to obesity disease increases exponentially. Obesity doesn't discriminate. Doesn't matter your race, your sex. As your BMI goes up, you develop other diseases. Typically, the ones we see the most are diabetes, hypertension, also known as high blood pressure, and the diabetes, I might add, is type 2 diabetes generally. Sleep apnea, it's when your partner tells you you're snoring at night and you actually may stop breathing. That's sleep apnea. It's treated with CPAP, and we'll get into that in a little bit later. Depression, joint pain, infertility, cancer, GERD, which is the acronym for gastroesophageal reflux disease, and asthma. These are listed in kind of descending order, with the top ones being the most common. The ones we see most frequently would be the diabetes, high blood pressure, and sleep apnea. BMI, what does that refer to specifically? Many of you already know, but we want to be thorough. Body mass index. If you plug your height and weight into a formula and your BMI comes up a number above 30 or higher, you have obesity disease. Obesity disease is then staged from 30 to 35, 35 to 40, and then over 40. As your BMI goes up, obviously your incidence of developing other problems, other diseases increases as well. But this slide here shows you, it breaks it down in the class 1, class 2, class 3, obesity disease. Whoops, sorry about that, gang. Got a little crazy with the clicker. Here are my two esteemed, better-looking partners, Dr. Radicke and Barbara Allen. She is our bariatric certified nurse practitioner, and we've been very blessed to have a Center of Excellence program here at Sebastian River Medical Center for now coming up over a decade. And we do over close to 300 bariatric surgeries a year. So we're very blessed to serve our community and greater Central Florida area. We're going to show you a few of our patients tonight that have actually been able to reduce their medications through bariatric surgery. Specifically, we're going to start with Amanda. She and her husband Kenny, ironically, their husband and wife, and I had the privilege of doing both their surgeries, not at the same time. They were staggered, so one could take care of the other while they recovered. Amanda has done really nicely and gone through the gastric bypass. She has come off of her diabetic medication. She's no longer diabetic. She's also come off of her CPAP. She no longer has obstructive sleep apnea. Her husband Kenny, I had the privilege of doing his surgery. He actually got a sleeve. It was a time period after Amanda. He also came off his metformin. He's no longer diabetic, and is also off his CPAP, no longer has obstructive sleep apnea. He's also been able to come off his high blood pressure medications. He needs to monitor it to make sure it doesn't creep back up, but he's off. So they're a wonderful couple, and we thought they'd be a great representation, one having the gastric bypass, one having the sleeve, and we're very grateful to them for allowing us to share that information with all of you. But they've done really nicely. And also they just celebrated their 20th wedding anniversary, so we want to congratulate them on that, and our hats off to you guys. You've done really well and demonstrated the medical benefits of this surgery by not only reducing your BMI, but becoming healthier through reducing the other diseases that obesity causes. Now you remember, go back to that other slide in your head, diabetes, hypertension, and sleep apnea. Kenny has no more of those top three, and his wife was diabetic, had sleep apnea. She doesn't have those two. So you can see the benefits of the surgery in very tangible ways. Your options for surgery, we also call it metabolic surgery because these surgeries really do alter your metabolism. A lot of people will have what's called fatty liver disease, and they'll go on a medical supervised weight loss diet and they won't be very successful. One of the reasons they won't be is because fatty liver disease impairs their metabolism in such a way that they really struggle to lose weight. These surgeries fundamentally change your metabolism, so it's important to remember that. There's a cartoon slide of the three. The two we most commonly perform, the Roux-en-Y gastric bypass and the sleeve gastrectomy. There's a third one called the duodenal switch, which I like to refer to it as a sleeve and a bypass. It's a sleeve on the stomach and a bypass on the intestine. That surgery is typically reserved for a select group of patients with obesity disease. Most people with obesity disease are successfully treated with either a Roux-en-Y gastric bypass or the sleeve gastrectomy. I'm going to go through each of these surgeries in a little bit greater detail. I'll also take your questions at the end, so if you're watching, please feel free to type them in to the box, and I'll be told those at the end of the informational session. The Roux-en-Y gastric bypass is restrictive and malabsorptive. Restrictive meaning we make your stomach a much smaller size. I like to make the analogy that we're going to make it the size of a tortilla. It's going to be small. It's going to be about 3 ounces. We're also going to reroute the way the stomach now empties. It's going to take a new exit, and that's the malabsorptive part. So you really get the benefits of both a restriction and a malabsorption. The Roux-en-Y is a very safe procedure. It's a very effective procedure. Oftentimes, Dr. Radke, Barbara, myself, we will see patients in the office that might be scared of the bypass, that will say to me or them, well, my cousin's brother's sister got it in 1980 and she's got a big incision and she didn't do well. Well, I'm here to tell you that the bypass that's done today is very different than the bypass that was done in the 80s. The technology we have, the instrumentation we have, make it a far safer procedure, a far more reproducible procedure with very safe outcomes. So I just want to caution people, and one of the take-home messages here is that the bypass is a safe procedure. It's not only highly effective, but it's safe. Over 98% of the patients go home in 2 days after the surgery, and you're able to get back to a normal life within 2 to 3 weeks after the surgery. You may not be exercising for about 4 to 6 weeks, but getting back to work, a lot of people these days work from home, work on the computer. They're usually back to work within 2 to 3 weeks with either the bypass or the sleeve. So important to remember that. It is the most extensive of all the bariatric surgeries studied, the Roux-en-Y. It's been around for about 50 years. There's lots of variations of the procedure. The one we do is very safe, it's protocol driven, and it has excellent results. As you can see from our model patient that we spoke about earlier, Amanda, she really is a great representation. Highly effective at putting type 2 diabetes into remission, she can say that. And 80% excess weight loss at 1 year, 70% at 10 years. So it has durability. Not only do you have excellent results up front, they last. A decade later, people are still experiencing not only the metabolic benefits, but the real weight loss benefit as well. 85% remission in type 2 diabetes, 75% of patients see a decrease in their blood pressure, improvement in cholesterol and triglycerides, those numbers that you get from your primary care doctor when they may put you on a medication. Oftentimes those medications aren't needed, they're taken away. And then resolution of the sleep apnea. That's an awesome thing. I've had several patients say to me, well, it's not very nice when I have to hook on this appliance at night and I look like Darth Vader. I sleep better, but no one misses the machine. And 9 out of 10 patients lose it. That's really a nice statistic. So something to keep in mind. Switching gears a little bit here to the sleeve gastrectomy. It's a very popular procedure these days. It removes effectively about 80 to 85% of the stomach. It takes the stomach and turns it into a sleeve. We don't put anything in like a lap band. Some people think, oh, I'm going to have the sleeve inserted. No, it's just the shape, new shape of your stomach. It looks like the sleeve on your shirt. It's just long and tubular. It's about 3 to 4 ounces depending on your original stomach size. This is a restrictive procedure and also biochemical in the sense that there's a hormone called ghrelin. That hormone is reduced significantly in sleeve patients. What that means long term, we have to admit we really don't know yet. But you will see patients that have a sleeve gastrectomy will genuinely see a decrease in their appetite for up to a full year after that surgery. We also, I might add, see decreased ghrelin levels in bypass patients as well. The sleeve gastrectomy has been done well over a decade now. I can remember doing some of the first ones in 2008. As I said, it turns the stomach into a long tube. Unlike the bypass, it does maintain the normal flow of food through the GI tract. Therefore, the effects on the diabetes in this next slide aren't as profound as the bypass. So sometimes people will say to me, what's the better surgery for diabetes? Typically, my answer is the bypass, typically. But if you've just been on metformin or glyburide under 2 years, so therefore you're kind of a newly diagnosed type 2 diabetic, the sleeve's a very appropriate operation for you. If on the other hand, you're on Ozempic or you're on insulin, you're taking insulin at home, the bypass or the switch is going to be a more appropriate surgery. But that being said, 75% resolution in type 2 diabetes, 65% reduction in your medications for hypertension, and 85% reduction in CPAP is nothing to sneeze at, no pun intended. Those are all very impressive reductions in what we call the comorbid diseases, or the diseases that go with the obesity disease. The switch, as I mentioned, you can see from the slide, is a sleeve on the stomach and then a switch on the intestine, not the stomach, a bypass on the intestine. So it's a very powerful metabolic operation, bariatric operation. It actually does have the best weight loss results. Let me go back just for a second. But there are some trade-offs, and those are the ones we talk about specifically in the office with a patient if they're thinking about the switch. In terms of risk and complications, obviously we've been touting all of the benefits. We want to tell you the risk and complications. Thankfully, they're very low. We have protocols in place. We do lots of these surgeries. We're a center of excellence for Medicare, as well as Blue Distinct, which is a Blue Cross recognized for bariatric surgery. So our outcomes are watched. We're very proud of them. We're grateful for them. But what are some of the things that can go wrong? Staple line leakage is one of them. We take this very seriously. We buttress our staple line with tissue reinforcement, which minimizes the risk of any staple line leakage. Bleeding or deep venous thrombosis, again, you receive a preoperative blood thinner, which you'll receive during the course of your entire hospital stay. Again, this reduces any risk of developing a blood clot. A lot of times people will ask, well, I'm already on a blood thinner. Can I still get surgery? The answer is absolutely. We would modify the medications and may change the administration, but you can definitely still get the surgery. Pulmonary embolism is just a blood clot in the lungs, similar to deep venous thrombosis, which is a blood clot in the legs, treated in the same manner. Again, our incidence of these is exceedingly low. And then obviously infection. Thankfully, we don't have a problem with infections. You'll receive a preoperative intravenous antibiotics as well as postoperative intravenous antibiotics. You'll also receive a special surgical soap before the surgery that you'll use at home. It's HIPAA soap, it's surgical soap. You'll cleanse your body with that prior to surgery. So we really don't have a problem with infections. The reality, take-home message, bariatric surgery is safe and effective. That's what you need to remember. Medical studies have demonstrated that bariatric surgery is actually less risk and complications than getting a hip replacement. I know I might get some private messages from my orthopedic surgeon colleagues when they see this. They'll be a little ticked at me, but the data is the data. These are safe surgeries, and that's what folks need to remember. In terms of preparation, there are steps for this. You have to be prepared. Like anything in life that's worth it, it's going to take time. And preparation's key. This is not like, not trivializing other things, a biopsy or, something done as a ingrown toenail. These are significant surgeries, even though they're done through little incisions, robotically and laparoscopically. In terms of that preparation, you get to meet one-on-one with the surgeon. We want to meet you. We want to talk with you, learn about you. What are your goals? What do you hope to achieve with this surgery? Not only from a medical standpoint, but also from a psychological and emotional one too, because these surgeries are very impactful on many levels. We'll have you get clearance if that's indicated with your primary care doctor, or if you have a heart history, you're going to get clearance with the cardiologist. We'll have you meet with our nutritionist. You'll meet with a psychologist. That's important. We want to measure mental motivation. Why are you doing this surgery? And are you going to set yourself up for success? Remember, these surgeries are tools. This is a tool. It's a very powerful tool, but it's a very effective tool. We want to make sure you use that tool well when you're given it. I can give you a hammer, and you can hang a picture up on the wall, or you can put a hole in the wall with a hammer. So we want to give you the education you need, because education, knowledge is power, to use that tool effectively. Obviously, if you have an insurance mandated visit, some insurance companies mandate multiple visits. Some are 3, some are 6. You'll just get to know us better. That's all. That's what that means. We obviously have you watch a video. You'll do preoperative preparation. Obviously, blood work, EKG, that's part of your medical clearance. And the surgical soap prescriptions, post-operative appointment, those are called housekeeping things. They're all very important, and they're all covered prior to your surgery. It takes time. It's going to be a few visits, but it's all worth it. And I will tell you that so often I get the comment for patients that have to do 6 months, they say, "Doctor, I can't believe we're doing the surgery next month." Time goes very quickly. We also offer medical weight loss for those of you that might not have 100 plus pounds to lose, might just want to lose 30, 40 pounds. You're not really a surgical candidate. We can help you with that as well. There are some new, relatively new FDA-approved drugs that are quite effective for medical weight loss. Alternatively, maybe you do have 100 or 200 pounds to lose, and you're just not comfortable yet with the idea of surgery. That's totally fine. As I said, I'm not trying to sell you a car. I just want you to know that bariatric surgery is safe. But this has to be your decision. This is your journey, not mine, not Dr. Radicke's, not Barbara's. You have to make that decision, and you have to have peace in your soul about doing the surgery. And once you achieve that, then we move forward, and that's important. We don't force the surgery on you. You have to ask us for it. Obviously, we're going to do an initial assessment, and the monthly visits are a little bit more common with the medical weight loss because we want to track your progress, and we all do better with accountability, whether it's medical weight loss or anything else. Another important thing to remember, if you've already had bariatric surgery, you can still have options for further surgery. For instance, just today I had a busy day in the office seeing patients. Saw a few patients that have had lap band done. Lap band was very popular in 2008 and 2009. In fact, there were more lap bands put in then than there were sleeves done. So now there are a lot of lap band patients out there. They were happy back in 2010. 2021, they're not so happy. They want the band out, or they want it converted to another surgery, say a sleeve or a bypass. So we can help you. Those bands can be removed. Sometimes it can be done all in one stage. Sometimes it can be done in 2 stages. Even if we didn't put your band in, we can take it out and we can still help you. So that's an important take-home message. And don't feel bad if you have regained weight if you have a lap band, even if you have lost a lot of weight initially. There's a few things to remember that are very critical about this. Obesity is a very tough disease, and it stays around, and it's something you have to battle. And again, this is a tool. The lap band, although we thought it was a great tool, is not the perfect tool for long term. So you experience success, now you may have experienced weight regain. Don't put yourself down. Just come and see us and we can talk about what options there are for you going forward. It's important to remember that. The cost of obesity disease is high. Why is it high? Well, remember all those comorbidities I showed you at the beginning, those other diseases that form as a consequence of obesity disease. Those are expensive. Medications are expensive. Going to the doctor, seeing specialists, they're expensive. And if you're at the doctor, that means you're not at work. So it's a cumulative, it's a snowball effect. So if you look at the results of this over a year, over $18,000 lost because of obesity disease. So it's important to remember that. People will say, well, obesity disease, bariatric surgery is expensive. Well, I would say lack of bariatric surgery is far more expensive. Medical weight loss obviously is affordable. It is covered by most insurance companies. We do offer competitive pricing for people that don't have that coverage, and you can contact our office specifically for those numbers. Thankfully, most insurance companies do cover bariatric surgery, and thankfully we're contracted with most of them. We take, obviously, Medicare, Medicaid, and all the major private insurers, being Aetna, Blue Cross, United, Cigna, Humana, and also TRICARE, Standard and Prime. Since we're in Indian River County, Brevard County is just one county. North of us, they have Patrick Air Force Base. We do see quite a few folks that have TRICARE. Remember, coverage depends on an individual's policy, not the insurance company. For example, Blue Cross Blue Shield does cover bariatric surgery, but you may have a plan from Blue Cross Blue Shield that doesn't include bariatric surgery. Now I'll just get on my soapbox just for a minute. It should be covered, in my opinion. Bariatric surgery is safe, and you really shouldn't have plans that exclude it. Could you imagine having a health insurance plan where you need a hip replacement and Blue Cross says, no, you can't have a hip replacement? It would never happen. But unfortunately, and the people that can change this are you watching, is discrimination against bariatric surgery. There are still health plans out there that won't cover bariatric surgery. It should be covered, in my humble opinion, in the most basic of plans. It shouldn't be an elevated, higher level plan, but it is. So you need to know that. So certain companies you work for aren't going to have it covered, even though they should. Again, my opinion. I'll distinguish fact from opinion, just so you know. So you have to pursue insurance coverage. You have to know, and your human resources department where you work can tell you, yes, we have bariatric surgery coverage, or no, we don't. And if we do, what are the requirements? Is it 3 months? Is it 6 months? And obviously, we want to be compliant and check all those boxes so we get to do your surgery. Why choose our program? Well, I think we're head and shoulders better than the rest. And that's not to say the other programs aren't good. There are many fine bariatric surgeons out there and many fine programs. I know most of them. But I also know what we invest in you in doing this surgery. We get to know you. We have a relationship with you. You're not just a number to us. You're a person with a disease, and we're going to help you address and fight that disease. And that's what you need to remember. There's really no greater privilege for me as a bariatric surgeon to get to participate and help you regain your health and regain your life. And I know the same is true for Dr. Radke. So that's something we take very seriously, and it's our privilege to be able to do that. And because of that, we're vested in you. We're vested in your success, and that's why you should choose our program. We're obviously a fully accredited program. MBS QIP are the letters. Don't worry, you won't be tested on that later, but we are fully accredited. And I also have Blue Distinct, as I mentioned earlier as well, and that's important to remember. We do have a monthly free bariatric support group facilitated by Barbara Allen. She's our bariatric certified nurse practitioner. She does a wonderful job. And this is a wonderful opportunity. If you're thinking about having surgery, you can attend this free support group. I think we just started meeting again in person. I'm going to call it a post-pandemic meeting, since I think we're more and more people are getting vaccinated. We're getting through this thing, and we're starting to meet in person. And you'll have an opportunity, if you're thinking about the surgery, to meet someone that's already had it, to see if they would do it again. Ask them questions. Dr. Radke and I are not there unless we're invited. So it's a very open, frank discussion that you can have about bariatric surgery. We typically have, from what I hear, 40 to 60 people attend. So it's a very good participation, and it runs about an hour. So I think it would be time well spent if you were able to attend. Whoops. We also have a post-op nutritional class. It meets on the first Wednesday of each month. Again, just restarting this as well. It's a great opportunity if you've had surgery and you are in the process of transitioning from liquids to what we call pureed, otherwise known as mush, before you get to regular food, because remember, you have to give time for this, the staple lines to heal, for you to recover from that surgery. And this is a nutritional kind of refresher for you. It really is, again, time well spent and educational for our patients. So what's the next step? You schedule a consultation. Sometimes you can get in to see Barbara quicker, and you'll have a consult with her, and then you can come to see Dr. Radke or myself for your second visit. You have to decide your treatment options. Where are you? What are your goals? You'll know that before you come in. That's really important. And want to take a few questions at this point. We have a question. You can send them in. I'll just mention one of our postoperative patients. She's 2 months out, Lisa. She just shared with us that she's been able to reduce. She was on 4 blood pressure medications preoperatively. Think about it, 4. That's quite a bit. She's now down to 2. So she's 50% reduced at 2 months. That's phenomenal. Phenomenal. Now, at 3 months, she's down to 1. That's really remarkable. So 75% reduction. We have another patient, Amanda P. She shared with us that she's been also able to get off 7 medications in surgery. So these are people that are sharing this online. And these aren't, we didn't concoct these before we got on with our presentation and said, we're going to show these people. These are real patients sharing their real experience. So it's important to remember that. We do have a patient, can I switch after having, can you get a duodenal switch after bypass? That's a good question. That's a complicated answer. And I think the best way for me to address it is technically say, yes, you can. But I'll also add that oftentimes your bypass can be revised so that you can continue to lose weight with it. Taking a bypass to a switch is not a trivial surgery, but it can be done. And we would have to talk more about it in detail. We just also have a question from Becky. I have bad reflux. What is the best surgery for me? I would say hands down, that's an easy one if you're a bariatric surgeon. It's a gastric bypass. The bypass is the best surgery for reflux. And obviously, you're also going to significantly reduce your BMI. So that's an easy one. Bypass every day of the week. we have someone that wants to attend a support group. If you do, I would just share with you an email. Please email our bariatric director, Jessica Miller. That's jessica.miller@steward.org. That's steward.org, steward.org. Frequent questions: how quickly can I come off my blood pressure medications after surgery? Obviously, we want to do this in a methodical way. Oftentimes, a patient will be on, say, 3 or 4 medications when they are discharged from the hospital. We will actually typically take the liberty of stopping one of those medications. And we do that because the patient has already lost 20 pounds and is on a liquid diet, and we don't want them to bottom out their blood pressure and come to the office feeling lightheaded and hypotensive. So we will already reduce one at discharge, and oftentimes the primary care doctor, their internist, will fine-tune those and decrease them at a subsequent visit. That's one of the reasons we say it's very important for you to see your internist or your primary care doctor within that month after surgery, so he or she can help fine-tune those medications. Because we'll reduce them, but the one you're going to be seeing regularly is going to be your primary care doctor. Obviously, question about positive impact of the surgery on diabetes, type 2 diabetes specifically. Will I be able to come off my insulin? The question is, usually, again, that's got to be done very carefully and methodically after the surgery. If you are on insulin and you say, for example, undergo a gastric bypass, we're going to remove that insulin before you leave the hospital. So we're not going to want you taking it. Most people are very comfortable checking their blood sugar at home. We're going to want you to do that. If you're on a metformin or glyburide, typically we'll put you on that oral hypoglycemic while you're home, transitioning your diet. Occasionally, you'll have to do what's called a sliding scale and maybe cover yourself with a little bit of insulin, but you certainly won't be taking the doses that we typically see 30, 40 units in the morning or 30, 40 units at night. It's going to be scaled way, way back. That's important to remember. Also getting a question, can you take ibuprofen for knee pain after the surgery? We usually tell people to refrain from taking ibuprofen or Motrin, Aleve. Those are all commonly or collectively referred to as NSAIDs, which are non-steroidal anti-inflammatory drugs. Especially if you have a bypass, that can upset your lining of your gastric pouch and the hookup to the intestine. And so we really want you to stay away from that. We recommend Tylenol arthritis typically. It doesn't mean that you never can take that again in the future, but it's not a medication you want to take in that first year after surgery, and you certainly don't want to take it regularly, okay? Another question we just got in: my mother had bypass surgery and lost a lot of her hair. Is this the same for every bypass patient? That's a great question. People do experience some hair loss following bariatric surgery, even if they got a sleeve and not a bypass. I am here to tell you, you will not progress to my level of global alopecia, but you may have some hair loss. The best way to address that is obviously you want to take your multivitamin every day, but also supplement it with zinc and biotin. Those are two minerals that will be very helpful in helping slow the loss. It's not going to completely stop it, but it will slow the loss. And I'm also happy to tell you that after about 4 to 5 months, the hair loss will stop. Your hair will regrow, and you will not stay in that negative hair loss mode for long. Once you've had the bypass, is there any way to tweak the pouch after? That's a common question. So sometimes we'll see folks that are 20, 30 years out from their gastric bypass that may have regained some weight. And sometimes they'll be told, oh, my gastric pouch has stretched. Can you make it smaller again? And the answer is, it can be made smaller again, but it's really not an effective way to go. You may lose a few pounds, but I certainly wouldn't recommend it. I don't think Dr. Radicke would recommend it either. Making your pouch smaller is not going to be a long-term solution. There are other options which are a little bit more complicated. So if you want, make an appointment, come in and see us and we can talk about those. Those have to do with malabsorption and changing the amounts of common channel and biliopancreatic limb. I told you it's more technical, that you have with your gastric bypass. So we could speak about those in person. I don't think we have any more questions. I want to thank everybody for attending this evening. And I'll leave you with this one final thought, take-home message. We went through a lot of the things that you reduce, those diseases, those medications, but I want you to remember what you gain from this surgery. Not only do you gain a healthier you, but you really get your life back. So many times I've seen patients gain things that they could no longer do prior to surgery, like get on an airplane and go visit relatives when they didn't have to ask for the seatbelt extender anymore. That is life-changing. Or being able to go to Disney and get on a ride that before they didn't get on because they knew they were going to be asked to leave the line. Or go on a vacation and go parasailing. The reason I mention these things specifically is because these are the things that have been said to me specifically by my patients, that they're now able to do that. So I want you to remember the things you gain, and you gain your life back. Please remember to join us next month. Dr. Radicke is going to be talking about working out and getting fit after bariatric surgery. I know that's a subject near and dear to his heart, so please don't miss that. And thank you for attending this evening.